It is 5:30, and I'm going to call to order. We have here for the Joint Central Health Board of Managers Strategic Planning Committee and Budget and Finance Committee. It's Wednesday, May 16, 2018, 5:30. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, boardroom. And I am now going to call to order the Strategic Planning Committee. We do have a quorum present. Item 1, and there's no action on this item, this is for informational purposes, is to receive and discuss an update on proposed strategies related to recommendations outlined in the Germane Solutions Performance Review for inclusion in the fiscal year 2019 strategic work plan and budget. And I believe Monica Crowley is here to present. Thank you, Monica.
Thank you. Monica Crowley, Central Health Chief Strategy Officer. As you all know, Central Health has been working internally and in reaching out to the community over the past few months to incorporate recommendations that were made by Germane Solutions pursuant to their performance review of Central Health. And we have been working with the community and internally to incorporate these recommendations into our strategic work plan for fiscal years 19 and 20. And tonight we are going to share some of the proposed strategies that we're going to include in the 19 and 20 work plan. We're not asking, like Ms. Greenberg, or Manager Greenberg said, we are not asking for any action tonight, but we're presenting the proposed strategies. And I think you should have a document in front of you. Many of you participated in this process over the past couple of months. So the strategies that are proposed in red should not look unfamiliar to you, but as a quick recap on the process that we've undertaken, on March 19th, we had our first of the community conversations with community members seeking feedback and recommendations from the community on ways that we could incorporate the Germane Performance Review recommendations into our work here at Central Health. After that meeting, we took the top recommendations that came out of the community meeting and combined them with feedback that we had gotten from staff and the executives about recommendations that could be implemented in fiscal year 19 and fiscal year 20. And there were many that overlapped and kind of rose to the top. And then we went to the community again on April 3rd and April 5th in community conversations to get feedback and input on proposed strategies that could be included in the work plan. And out of the groups on April 3rd and April 5th, there were 3 themes that really stood out from the community members, and those were around transparency, communication, and improving specialty care. And as you can see, the recommendations that we're proposing, including in the work plan now, follow these themes around communications, improving specialty care, and around improving transparency. Right now, what we're asking for is for you to take this document, to read it, to absorb the information in it, and we aren't asking for any action tonight. However, we will be coming back next month, and Lisa will be presenting on how these strategies crosswalk and interact with the proposed budget for fiscal year 19.
Thank you. Questions, Erin?
Thank you. Yes. Thank you, Monica. Appreciate it. I've been into a couple of these community conversations.
Let me interrupt. Could you pull your microphone a little bit closer?
Oh,
Thank you.
is it better now?
Yes, thank you.
I've been in a couple of those community conversations, and also in one point that I don't see how we're going to change the next fiscal year. Where are we in addressing the social determinants of health? So just wanted to look at that.
Let me know. So, if if you look under what's strategy 1.2, and again, all of this is just, the purpose of tonight is just to get the document in front of you and explain how it's laid out. But we anticipate a lot of discussion around this, but under 1.2, population health social determinants, it says provide funding or reimbursements to provider partners for resources to establish population health goals and address specific social determinants affecting the population served. And again, this is an overarching strategy, and you can imagine that under any strategy, there could be half a dozen to a dozen projects underway through our provider partners. Right now, there's a community health worker pilot project underway with Winston-Meditano as well as CommunityCare. So there'll be a lot of discussion around this, but ultimately what this strategy will do is, instead of central health setting up individual siloed programs, if you will, we're actually combining them and working with our provider partners so that these social determinants programs, whatever form or shape they may take, are actually part of the medical programs. And so that way they're more integrated around the patient care and centered around the patient. And that way, if a provider needs to, or a patient for that matter, or a patient's family needs to activate the care system to be able to deal with a social determinant that affects their health, they can do that. They're not passed off to another program.
But, and let me just
Again,
add
this is
something.
just a proposal.
Yeah, and let me just add something. As you will recall, in the strategic planning committee, this is an item that we will be continuing to work on. So we had an initial discussion of this in fact, in this room, in a strategic planning committee meeting where we had presentations. We came back last week, and Shannon, I know you couldn't be there, and so we're going to repeat some of that information for you tonight, and had additional information that was requested. But you will see this item on strategic planning until we have worked through it and are comfortable with where we are headed with population health and social determinants.
And it's the prerogative of any board member throughout this process to want to amend this. And it could be, through a motion or resolution, you can come back in.
Meaning what's in front of us
Right.
tonight.
Right.
And we don't have to do it right now, correct?
No, we're not
No,
taking
in
any
fact,
action
I
tonight.
would
Just
encourage
zero.
you. Read
Another
through it.
piece, I appreciate, thank you too. Can you elaborate more? Provider partners, who will they be? I think we need more clarity on that piece.
Monica?
To add clarity on who providers, partners are
If we're
in this
gonna
strategy?
focus it here, or reimbursement to provider partners, I just don't want us to come across a situation that it's very ambiguous. Are they our partners, are we not? Can we move forward with any funding?
That's still to be
You just
determined.
wanted some,
Right, and I'll own up to that phrase. The reason that I drafted it to read provider partners as opposed to saying CommunityCare or Lone Star or fill in the blank is that when we think about provider partners, it's entities that we are reimbursing to provide care.
Right.
okay.
And if we need to spell that out in the course of the minutes as the board deliberates this document, we can certainly do that. But again, I think also when you start, and we'll talk a little bit about reporting here, and we have a slide that kind of explains how we'll report on these strategies. I think to understand each individual project from the specific providers and what they're doing to help us execute on this strategy will be something that you'll have access to as a board.
Now, this is wonderful. I just wanted more clarity in the future if anyone else comes into, like, are we doing nonprofits outside of our partners, whatever. It's just more clarity.
Absolutely.
Thank you.
But my plan is that we achieve that clarity through the strategic planning committee and our ongoing work on this subject.
Point well taken. Understood.
Yep, I agree.
And part of the information that we'll be bringing back too is also, as Mr. Giesland said, we'll be bringing back information about reporting dates and when you guys can expect more reporting and more milestones on these as well as part of the broader.
Anybody else? Cynthia?
Yes, just to elaborate on what you provided us, Monica, what a good idea, and this is what I asked for, because I looked at this today, because we didn't get it until today, but it looks quite familiar to something that we'd seen before, and I think it was something that you had provided to us. And so I asked Emily if she could give me the original copy, And so maybe it might be a good exercise to distribute the original that this is an improvement upon or expanded upon this, so that we would be able to see the differences in the language, because there are some things here that I liked here that didn't quite make it here, especially with respect to measurable outcomes. So maybe it would be a good idea to look at our original document. Mike, I think you're the one that provided this to us, maybe somebody did.
I think that was for the
Actually,
community
JP put that
conversation.
together.
Put
for
it
us.
together, thank you, JP. So it would be,
Trying to be that talented.
no, so this would be a good, at least to be able to discern the differences between the two. And if there's something that's not necessarily capturing, if we want to expand upon it, as in strategic
Right.
planning, as we continue with the process. And if we want to make suggestions, do we direct them to you? Do we direct them to you, Sherry? How do you want this to work?
I think Monica and I will communicate, right? And so I think the best is to direct them to Monica. She and I will communicate on the agendas and meet and make sure that we are synced up. And when you say the original, are you referring to the document that was provided for the original community feedback meeting? Is that what?
This has been an iterative process, and
I just don't know what.
yeah,
this
and
referring
I'd
to
have
as the
to,
original.
I think what she's holding up was probably, this was a summary version that was prepared maybe a couple of months ago.
Oh, for the Germane report. Got it. Okay, I understand which one it was.
Subsequent to that.
Yep,
But
I know what it was. Okay, thank you.
You can get that from Emily.
Okay,
Anybody else?
And just thank you. And so with respect to this, I'm sorry, you said,
Direct it to Monica.
give it to Monica.
Yes, ma'am.
Okay, would you like for us to shoot you a copy or not?
Monica will get with me. Don't worry about it.
Thank you very
Make it
much.
simple for you.
I just wanted to make sure that in our strategic planning process, before we actually take a vote on formal language or strategy approval,
Right.
that we have a good conversation
Oh, it
about.
will all be vetted.
I appreciate
Yeah,
it. Thank you
but
very much.
don't worry, just communicate with Monica and then she'll
Okay.
get with me as needed.
Thank you.
Anybody else? All right. Thank you.
one quick, I'll draw your attention to the screens.
Yes, and I love this. I
One
saw
of the-
this earlier. It came out.
Key functions of a strategic plan is to tell you where the organization is headed, and the way to do that is through reporting. And reporting was addressed in their Germane Solutions report, and so this is more of a management function, but it translates upstream to the board and how it functions and leads. So there are, we get information through our partnership reporting, but also population and community health data, as you see down at the bottom of the screen. And I'll direct your attention to the left and then the far right of that table, but on the left are dashboards. And the dashboards are real simple. They show basic inputs and outputs. And the analogy that I like to use is that of a car dashboard. It's how much fuel you have, it's what your speed is, what your RPMs are, and it's just the basic measures of how the vehicle is performing. And you've already seen some of these dashboards. We've talked about the financial. We have previewed other dashboards, just betas, just to kind of test them out with the board in packets. But we're streamlining that, and you'll see the more streamlined and what I would say near final versions future board meetings here over the next, this coming meeting as well as the next one. On the right are the strategy updates. Now with the strategic plan, the dashboards are almost agnostic with respect to what a strategy or what your business plan might be. These are the sorts of things that you need to be looking at in any organization. On the right, however, it measures the efficacy of the strategic plan. In other words, is your strategy causing you to achieve the objective, or are you achieving the objective by accident? In which case, what is that accident? And let's replicate it. So the way you'll receive updates on strategies is you'll have simple cover memos in your board packets, but you'll have presentations that may involve 2, 3, 4, however many entities are involved in helping us achieve a strategy. Remember, everything we do, we execute through our partners. So what I would propose to you, and I would ask you to take this information and we can have a discussion at the next committee meeting,
Yes,
is
we will.
instead of having CommunityCare come in and just update on CommunityCare for the year or the quarter, or Integral Care, or Dell Medical School, we bring those individual partners in to help inform us on how are you helping us be successful with this particular strategy. And I think it ties everything together nicely, because then you can see whether or not those partnerships are effective as a means to an end. So I'll throw that concept out there. I just wanted to get the slide in front of you to tell you, this is how you'll be informed of this.
So Mike, just one question.
Yes, ma'am.
To be able to know if the efficacy of the strategic plan, according to those deliverables I see on the right-hand side, we have to have outcome measures.
Correct.
And so by having those outcome measures, and I totally agree with you, we don't want these partners to just come in and report, here it is, and without any mooring. And the strategic plan is what is our mooring, right? But in order to know that efficacy, that strategic plan has to have outcome measures. And then when they come and they report according to the strategic plan, the efficacy will be, what are the outcome, are you achieving these outcome measures?
Right. And
So-
and when I say memo, it's not just going to be narrative. It's going to be mixed, both quantitative as well as qualitative
But-
information that gets presented to
But
you.
what is going to be the process of determining these outcome measures?
I would say initially starting out, it would be at the management level, because, and to some extent, it might be an iterative process too. So measures that you start out with may fall off as you start working towards a particular strategy. I don't know that I would be in a position, that we would be in a position as a management team to bring you an entire set of outcome measures for each strategy, because each strategy may have,
Right.
like I say, half a dozen projects, and each one of those projects may have its own set of
But-
sub-measures
But I
for
guess
each one.
my question is there an initial set of strategies for which we will be receiving outcome measures that we can then judge the efficacy against?
Yes, and that's the whole point of the reporting on the right.
Right, and
Yes,
so
ma'am.
at what point will, I assume, strategic planning and then the board be presented with these initial outcome measures?
So what's not on the document in front of you is a reporting schedule, and we went back and forth on this, and we decided, okay, just for tonight, we'll cut
Great,
this out.
okay, so that's coming.
But there'll be a
in June.
reporting schedule attached to
Great,
each objective.
okay, and that'll be, we'll hear more about that in the June strategic planning committee meeting?
Yes.
Yes.
Wonderful, thank you. Okay,
Thank you.
Shannon and then Cynthia.
Quick comment.
I agree with what you're saying, Shara. I just have a question in terms of process versus overall outcomes. So in the development of those process measures that we can measure more intricately versus overall outcomes, which we'll do more, it would be helpful to see who determines what goes into that.
Right,
And so I guess that's where my question is that, will we have a process, we will have the opportunity to give input, or is that something you bring to us? How will that work? And I know it may be a little early now, because I'm sure you're probably doing some.
I would say it would come through the strategic planning
Right.
committee up through the board.
yes.
Both process and overall
Yes.
outcomes.
Right.
And so management would bring both process and outcomes to the strategic planning committee. We would have presentations and vet, and then I would see it going to the board.
Okay. So we would have the opportunity to have input at that point.
Yes, at the committee level, we would have input on both.
And these strategies are designed, this is what we've laid out before you as a plan that takes us through 2024. But if you'll notice on the prior document, it's FY 19 through 2020. And so these strategies, we've stretched it out and put it on a 2-year cycle. So there's a lot of, I would envision at a minimum 3 reports per strategy. One to start off with, to say, these are the projects that we've identified that are going to drive this strategy, and then you have a measurement, and how we're going to look at this, how we're going to measure it, and then you have a measurement, and then you have a final outcome on each one. And we've actually developed some very simple strategy sheets internally, just to be able to help us track those sorts of things, and what is it that we're going to be measuring.
Okay.
Cynthia, do you have something else?
And in some of the comments that that I've made in previous, when the previous presentations were presented to us, when we know what the baseline is, in order to do, first we have to have our baseline. But initially, in looking at the development of provider partners and whether or not their expertise is suited to the particular program that they're going to be addressing. One of the things that I'd asked is whether or not they have proven success in that particular area that this not be new to them. It be a proven success in that particular area, and what that is. Because if they can show us historically that they were addressing a particular issue, a particular problem, and that they actually helped to resolve that issue or to diminish the gap that exists, that was something that we needed to incorporate. So I just wanted to make sure that we have a chance to look at that precursor, which I think is what you were talking about, Shannon. Initially, how it's going to be set up for what determines who it is that's going to get funded based on what. So it would be really important to know those.
Of course.
It's important to establish those minimum qualifications for the submittals, and
Of course.
and looking at the organization as itself and historically, and whether it has had success.
Anybody else? All right, well, thank you, Monica, and everyone else who contributed to this. Really appreciate it, and we'll look forward in June, in the June Strategic Planning Committee committee meeting of continuing this overall discussion and hearing more from you, Monica, on the particulars.
Monica, personally, I would like to, if I may, Madam Chair, I would like to thank you and your team for this great
very
work.
much.
It's, and Ted, you know, with the community conversations being part
Absolutely.
of this, and it's been an incredible process.
That's why I said everyone involved, because I knew I'd miss somebody if I started naming names. Thank you all very much.
Team.
Yes,
I
the
want to
team.
start calling her Marvelous Monica.
Okay, the second item we have is receive and discuss a presentation on an update to the Central Health Demographics Report with an overlay of the Community Indicators Report data. Some of us I know heard this at the Strategic Planning Committee meeting. It won't hurt to hear it twice. It was a wonderful presentation. I know that Shannon had something beyond his control and was not able to attend, so I wanted Shannon to be able to hear this information. So thank you for your repeat performance.
Well, thank you for having me. Good evening, board members. My name is J.P. Eichmiller, Director of Strategic Communications here at Central Health. And the purpose of this presentation is to give you an update as to the progress and the collaborations we've developed in the wake of releasing our Central Health Demographic Report in November of 2017. Some key takeaways from this I'd like you all to basically report to you is that I'm very pleased to say that Central has become very much a leader in our community when it comes to identifying areas of needs. Everywhere, and I've personally met with dozens and dozens of government, nonprofit, educational, all sorts of providers in the community, and one after another they've come back and said, you have helped us identify areas we want to be in, the areas that you're going to be working and serving people in. But not just, and that leads to the second key takeaway, is that I really believe what I'm seeing is an activation of the information. We're not just producing data and reports. We are working with others to actually use this information to change and improve people's lives, specifically our patient population. Most of you have seen these many times before. These are the 40 census tracts we're projecting to have the highest concentrations of poverty in 5 years. And from those projections, we developed these 9 focus areas. And this has really been what we've been, when I talk about the areas that our partners want to help us and also want to help contribute in, these are those 9 areas. So here is a quick overview of the current data collaborations that we are active in right now. I put the Eastern Travis County Health and Wellness collaboration at the top because in one way or another, all of the other ones on these next 2 slides are feeding into it, or we believe they will in the future, as well as helping other projects. This collaboration represents more than 16 public, nonprofit, and educational organizations. It's been led by Larry Wallace, and we are, as many of you, as he presented to the board last month, we are actively working with that group as they look at different areas to help them understand and analyze the demographics and the needs of the population in those areas. And one of the most exciting ways we're doing that is the second point on the slide, the health indicator overlay. So this is utilizing the collaborative health planning group, which is a interlocal agreement that we had formed many years ago between Austin Public Health and Travis County and Central Health. They created the Healthy ATC website, but we are utilizing the expertise in this area, the analysts and the planners, in a new way that we haven't done before. The first thing we were doing, we decided to do a test run with these people and with our information in the Colony Park area. What we wanted to do was specifically run our data, run the data of the partners over these areas, and see what kind of critical health indicators we could identify as we're doing service planning in that area. So that as we look to stand up facilities, we're really going in with our eyes open. This includes examining areas such as the rates and causes of mortality, birth outcomes, teen pregnancies, and prevalence of specific diseases such as cancer, heart disease, mental health. And we're also looking at other associated risk factors such as education, cost of living, and migration patterns due to increasing costs of living. So what we're looking to do with this is really, this is the first step. We do the analysis and the overlay of our data, and then this group, the Collaborative Health Planning Group, will identify some of the most important indicators. And then following that, we'll develop an evaluation plan and bring that forward to the Travis County Health and Wellness Collaboration. So we really see this cascading back. Again, what I said earlier, we're not just collecting data for the sake of it, we're developing a plan of how we're going to use this, and we're really going to be more effective as we step into these areas. Really quickly, I'll go through the others. We're working with the CCC to do a patient utilization analysis. This is of our MAP patient population. We want to identify utilization at hospitals, who's going and who's utilizing primary care, who's utilizing the hospitals, where do they live, and where are they going. The Travis County Transit Development Plan. This was, again, another result of a meeting we had on chance just to talk and share data, but we quickly became very integrated with this process. And in fact, on the plan that they presented to the Commissioners Court last month, we were identified as one of the first, as one of the next year that they want to develop plans for servicing some of those areas we highlighted earlier. Community resilience planning. We're working with the Austin Office of Sustainability. They're seeking a grant through the City Council. They want to increase education and awareness and responsiveness to natural disasters. And again, they specifically, after reviewing our report and talking with us, they decided they wanted to focus in on the Dove Springs neighborhood that we highlighted. These are future and/or developing collaborations. I've actually had the privilege of meeting with several of these folks just this week to see how we can keep building on these relationships. Children's Optimal Health, we are a voting member of their board. We're very excited to start utilizing some of the information they have. They've got a very deep database as far as school ISD information and data. Some of the stuff I saw today includes insurance coverage within the different schools, and they have a lot of information as to families as well. So in many ways, this is more real-time data than we can even get from the census.
Yeah.
So we're very excited to use that. United Way, I'm actually going there tomorrow to talk with them and visit their call center.
211.
Correct. They've got, what they've told me is they've got a lot of data as far as when they receive calls, what services people are asking for, and where those people live. So again, this arms us with another tool of understanding what the different needs from different people in our community might be. The Community Development Block Grant Program, this is a subset of the city. They deal with HUD grants. They also have a a very long-standing depth of qualitative data. We've met with them a couple times, and I'm very excited that we can start integrating a lot of the community needs assessments, the surveys they've been doing for 12+ years, so that we aren't going into communities that have received surveys and been asked what the issues are for year upon year and aren't getting the services yet. So we don't want to repeat that process. We want to utilize the work that other people have done. And finally, ECHO, we've met with them and had some preliminary discussions as far as what kind of projective analysis they may be doing and how we might, again, it's a learning and sharing collaboration on information with them.
And I would just like to add that Sarah Wheat was also there from Planned Parenthood and provided some information. And Sarah Cook provided a lot of information of things, data that we're sharing with Dell Medical School and others. And JP, I want to thank you and your team again for this excellent work. We appreciate all that you're doing. We look forward to seeing the progress that is made, but I really want to thank you and your team.
Thank you.
I know we discussed this. I'm going to start with Shannon because we had an opportunity last week.
Yeah, just a couple of questions, and we've already talked about them already, but, and I appreciate the work you've done. You've really done some great work. It goes a long ways. Under the health indicator overlay, is there conceivable at this point in time, I know you're working probably with public health and
Right.
Travis County, that you could begin to insert some of the mapping, the health data indicators, along with this other information for these areas, so that when you're out presenting currently and in the future, that they can see the relationship to the need for services, the absence of services, with the health indicators that currently exist. I think it makes the case a lot stronger. And so that's why I was asking on the morbidity and mortality
Right.
data. All of these areas you've indicated are the exact areas where, when you look at the critical indicators report that the city puts out,
Yes,
are high level. So the question is, that just further supports.
right.
So I was just wondering if you can inculcate that sooner than later in your presentations.
Also, is there a way through Healthy ATX, the website that debuted, I don't know, it was a couple years ago now, I haven't looked at it in a
I
while.
believe we're moving away from using that model.
Okay,
But without getting into specific dates, I can tell you, yes, we are trying to move this forward as quickly as we can as
Good.
far as integrating it with our GIS mapping software.
The reason
okay.
I asked, because the other night at the presentation here, you did an excellent job of presenting this. The only thing that was missing would have been,
Right.
and these are the same areas that we have high rates of cancer, diabetes.
Sir.
And I think that makes the case a lot stronger. So that's the only reason I'm
And
emphasizing that.
and I'm glad that you're moving to a new model, because as I said, I haven't looked at that website in a while.
We noticed that not enough, yes. We
Yes,
were
so
lacking on some visits.
I am appreciating your new model, and everything you're doing. And yes, if we could, with the GIS mapping that we have here,
Yes.
I'm wondering if we could, people take in information different ways. It would be good to have the numbers on the diabetes and the morbidity and different diseases go along with it, but would there be a way to do some heat mapping too?
Well, it's already mapped.
No, I mean we'll talk about it more.
No, I'm saying it's already mapped. It's just a matter of using the maps that already exist.
Right.
As part of the presentation. That's all I'm asking you. You don't have to go and recreate them.
So could it be
That's one of the things I
merging
talked
the
about.
data?
I just want to caveat
That's
that
the only way.
I believe the maps that have already been created are based on zip code. So
Right.
we're going through the process of trying to overlay with the
That's what I was
census
talking about,
maps.
heat mapping it,
No.
yeah.
Then we can compare and contrast the data you saw the other night. So we just want to have one set standard instead
Exactly.
of saying, here's zip codes, here's census tracts.
I'm sorry.
And that's what I meant, yeah, when I said, exactly, thank you for explaining, you knew what I was thinking. Maram, and then Cynthia, and then we need to keep moving.
Just really quick, I think it could be an easy fix. It's just to merge the data together. What you have to give more of an overlay of more geographically than assessing the needs. So if
So-
you have two data sets, just merging these two datas.
I'm gonna let staff
And
figure
I'm
it
just
out.
saying, it's really not complicated and for the future.
I'm gonna let, they're doing a tremendous
Oh,
job. They
I
know the
have
direction we
no
wanna move in. I'm gonna let them
About that.
figure out because they're working with a lot of different data sets, some census tracts, some zip codes. They're trying to, for lack of a better term, normalize everything and get it into our framework. Am I
Yes.
correct with that, JP?
Yes.
All right. But I understand. Cynthia?
So just real quickly, I just wanted to say one thing about the community resilience planning. One of the things that we did when we were working the floods in the Dove Springs, Onion Creek area, there was various organizations that came together, Manantial, the neighborhood associations, just different groups, Latino Healthcare Forum, but a lot of organizations that have members there. And they put together a report and presented it to FEMA, to the city of Austin, to different organizations, telling them what the initial problems were, what they saw immediately, and then the fixes, the possible solutions that could be incorporated quite easily into addressing a next flood. And so, they've gotten better and better. But it would be good to see if you could get a copy of the report that was submitted. And maybe George Morales would remember, because George was one of the, and since he is a Travis County Constable now, at the time he wasn't, his office had a lot of information.
What was the name of the group again?
Well, it was various organizations that came together.
Flooding, yeah.
And, but it was, Mona, it was Jill, it was Isabel, it was Francis, it was Ricardo Zavala. They were all these various organizations,
Yeah.
and
Right.
they put together a pretty comprehensive
did.
report. And so that would be a good thing to see, at least for that area, because, I mean, I can tell you one thing, the flood happened, and there was only one 911
Right.
person on call at that night. And then subsequently, they housed the
Right. I
resource
remember all
at
this,
Dove
yeah.
Springs Rec Center,
Yeah.
and nobody could get there.
And that's why
And-
they're
and-
looking at Dove Springs. Lucia Athens in the city's sustainability office chose Dove Springs. I
And
think.
they did not even
Flooding.
have any Spanish speakers to help the community. So initial things, but just give them a holler.
Appreciate it.
Thank you.
I have one quick question, JP. When you talked about the community development block grant and you're right, there are surveys done annually. Are these ones that are being done by the county or the city or both?
They're being done by the CDGB. When they institute HUD programs,
Right,
they're
but
required.
Neighborhood Housing Community Development at the city does.
Oh, I'm sorry, this is the county.
Okay, so just FYI, the city is doing them too. So I would also, you might want to touch base with Neighborhood Housing and Community Development at the city.
Yes, absolutely. The
Okay.
interest that I had what was so great about what we found with them is they were looking at areas such as Hornsby Bend,
Right.
Hill Valley. I mean, they've been out in those unincorporated
Right.
areas for so
Right.
long.
I was just thinking, when you said not duplicating, you might want to get with the city too and see what they've done.
Okay.
All right.
Thank you.
Anything else, members? Well, it is 6:08, and what we're going to do now is conclude as the Strategic Planning Subcommittee of Central Health and take about a 5-minute break until 6:15. There's some food in the other room, and then we will come back, and our chairman will call us to order for the Budget and Finance Committee meeting, correct?
Thank you, Chairman.
All right, so see you at 6:15. Yes, there is food over there. All right.
Okay, I would like to move forward. Okay, I would like to move forward with the Budget and Finance Committee. It is 6:20 PM. I'd like to thank Chairman Greenberg for being so efficient with her meeting, so I'd like to hope to do the same with mine. First, to outline, if there are no objections, the Budget and Finance Committee items that will be taken in the following order. Item number 6, item number 7, item number 8, item number 3, item number 4, item number 5, and item number 12. So, at this time, I would like to lay out agenda item number 6, discuss and take appropriate action on an interlocal agreement between Central Health and the Public Employee Benefits Alliance to participate in an employee benefits purchasing cooperative. And I would like to turn it over,
You gonna make a presentation?
yes.
I'm just gonna.
She's gonna make a motion. All right.
I make a motion, well,
Good.
good.
Love it.
We will, hopefully we'll get there really, really soon.
Maybe we can have a 60-second explanation, 60-second motion.
There you go, Nicole.
So this, it's really it's a new agreement, but it's an existing agreement that we've been in since 2007. And the reason that it's coming back to the board is that it's an interlocal cooperation agreement with an organization called PEBA, the Public Employee Benefits Alliance. And basically that's an organization of local governments that has joined together to essentially use their buying power to enter into agreements for employee benefits. And so the reason that we've brought it back to the board is that PEBA has updated their standard agreement, which requires board approval, again, for us to continue into this arrangement with them. And it's really beneficial. It provides access for HR to access employee benefits, such as the Employee Assistance Program, which is what we currently use it for Deer Oaks EAP. But there are numerous products that HR would be able to access without going through the competitive purchasing process, and it's also more economical. They're able to save the organization money. There's no fiscal impact. It's a $150 annual membership payment, and HR actually budgeted for that in their budget this year. So I'm happy to answer any questions. The agreement and the memo are in your backup, and I think it's pretty straightforward. The agreement didn't change from what it was in the existing agreement. There were some minor administrative cleanup issues and minor wording changes, but other than that, the substance is the same.
Thank you very much.
You're welcome.
Appreciate that. That was nice and succinct. Before we go on with asking questions or discussion, I'd like to have a motion put on the floor. Cynthia?
Second.
Yes, I move that the committee recommend that the board approve an interlocal agreement between Central Health and the Public Employee Benefits Alliance for membership in its employee benefits purchasing cooperative.
And do I have a second?
Second.
Okay, any discussion? Any questions? Shannon?
As a new member, just quickly explain, what is the benefit? What do they do specifically for us?
So the benefit is that since they have cooperation from a variety of local governments around the state, they are able to essentially use that as bargaining power with entering into contracts with vendors by basically the power of numbers, having numerous organizations.
So is this similar to what, in terms of function, what TML does for the Texas Municipal League does for municipal governments?
But I believe they do have a purchasing cooperative, yes.
Okay.
Yes. So it would be similar to there are numerous purchasing cooperatives. The state
Right.
has one.
State has it for IT.
The state has it for IT, and
Okay, all right, then, that was what I was trying to do.
Any other additional questions? Okay, I have a motion by Ms. Valdez. I have a second by Manager Greenberg. All in favor?
Aye.
Any opposed? Any abstentions? Motion carries. Okay, thank you very much. Agenda item number 7. Discuss and take appropriate action on the following amendments to the agreement between CommunityCare Collaborative and CommunityCare for primary care services. A, amendment for expanded dermatology services, and B, amendment for the addition of community health worker services. And I'd like to recognize John Morgan to give us a presentation.
And I actually don't have a presentation. I'm just going to present from the memo that's in your
Perfect.
backup
Right.
packet,
Members, that's on page 49 of your packet.
which has a lot more detail than I'm going to go into. I hope to be as succinct as Nicole. I'll try my best. So this is, as Dr. Bell mentioned, two items rolled into one contract amendment that we're hoping to execute with CommunityCare. Just as a reminder, as we make amendments to agreements with affiliates of Central Health or Seton, those are member-reserved powers specified in the CCC bylaws. So just like the last CommunityCare amendment that I brought to the board, this amendment does not require any additional funding. This is simply an amendment to make changes to the language in the CommunityCare contract, and these services will be provided within the same contract NTEs that already exist. So the first item that I'd like to present to you is related to expanded dermatology services inside of CommunityCare. This is the second of a 5-part strategy related to dermatology services for us. The first was executed in 2017 when we relocated the dermatology services from the Brackenridge Hospital campus into CommunityCare, into a community-based setting at South Wellness Center. This second part is about expanding the availability of those clinic services. Today, CommunityCare offers 2 dermatology clinics a week. We will initially add an additional clinic per week, so increasing by 50% the clinic capacity, and then based on the need and the availability of staffing and provider time, we may expand to an additional half-day clinic per week for a total of 4 per week. As you all know, we have significant wait lists and extended periods of time that our patients have to wait to access specialty care services. Dermatology is one of those. Today, we have approximately 900 patients that are on a wait list, and many times those patients wait in excess of 6 months to receive services. So this is a part of our strategy to impact that. I referenced a 5-part strategy, with clinic services being the second piece. Additional services that you can expect to see me bring back are expanded Mohs surgeries related to the downstream services that are needed from the clinic. So these are surgeries where the pathology is reviewed as the surgeon is taking, they're taking their biopsies or removing skin from the patient. They're reviewing the pathology in real time, and that service has to take place inside of the hospital. So part 3 of this is an expanded services arrangement with Seton for those expanded Mohs surgeries. And then parts 4 and 5 we'll likely see in fiscal year 19, which include an e-consultation service provision that's related to the fibroblast system that we're putting in place later this year. We want our primary care physicians to be able to work directly with the specialist through this platform and be able to answer the questions that they have about their patients, hopefully without having to send the patient to a separate visit. The 5th part is the more full-blown dermatology telemedicine, where we can put a patient in front of a camera with a dermatologist on the other side of it, and that patient's being looked at and diagnosed in real time. The provider can then tell the patient, tell the primary care physician if they need to follow up in the clinic. So this is the second step of that 5-part series, a lot more to come. but we really look forward to eliminating the wait list and getting to a sustainable model for dermatology going forward. I'll move on to the second item, and then I'm happy to answer any questions. The second item is another strategy that was outlined as part of our FY18 budget process and is in our strategic plan, which is making extended care team member visits available and reimbursable with our primary care providers. That's a menu of different care team members that enable us to take healthcare out of the clinic and put it in the community. It allows us to have each member of the care team work to the top of their license, and as a result, it creates additional capacity in primary care so that if a patient's real need is with a dietitian and not with a primary care physician, we provide the financial support for that dietitian so that they don't have to go see the primary care provider for the clinic system to get paid. So these are non-traditional services. Most health plans don't reimburse for a lot of these services, but this is a big part of our primary care strategy. CommunityCare is currently contracted with Latino Healthcare Forum for 3 individual community health workers that speak Spanish, English, and French. And they're used,
Arabic.
They're deployed across, I'm sorry?
They also speak Arabic.
And Arabic, thank you. Appreciate that. They're deployed across the community care system, work out of several different sites, and they offer a variety of services to our MAP and sliding fee scale patients. Each of our clinic systems really employs these extended care team visits differently, and we like to allow for that flexibility in the way that we contract with our providers. Each of their care models is different, and we want them to be able to adapt the different resources to their care team models. So with that, I would reiterate that this is just a contract amendment without any additional financial impact. There is a dermatology budget that you'll see later tonight in the CCC financials. I believe it's $90,000. That funding is available as needed for these services, as well as the additional Mohs surgeries that I talked about, and I expect to bring back a contract for your approval later this year for those Mohs surgeries as well.
Thank you very much, John. I appreciate that. Before we get into discussions and questions, I would like to get a motion on the floor. Autumn?
What number is it again?
Number 7.
It's in blue,
I move that the
yellow.
I move that the committee recommend that the board approve the following amendments to the agreement between the CommunityCare Collaborative and CommunityCare for primary care services. A, amendment for expanded dermatology services, and B, amendment for the addition of community health worker services.
Thank you, Manager Musaitif. Second?
Second.
Manager Valadez seconds it. Okay, is there any discussions or questions for John? Cynthia?
With respect to the dermatology service you mentioned, okay, so we have the 900 patients with an average wait time of over 6 months. Do we know what it, again, baseline, and we've been doing this for a little bit. Where are we? Have we?
I'm glad you asked, and this, I think, ties to your earlier conversation, and I don't want to get off topic, but part of what you will see from us related not just to dermatology, but across specialty care, is a dashboard that lays out over time the wait list by specialty, so the number of people waiting and that average time. The data, to be completely honest, is not great today, and that's part of the benefit of this system that we're putting in place this year, the fibroblast referral management and e-consult system, is that we'll have more reliable data. But we don't want to wait for that. We want to show you the data that we have as we have it today. We have an initial version of that dashboard that we're reviewing and cleaning up right now, and that'll be coming to you all in the fourth quarter of this fiscal year.
So what are you telling us? Are you telling us that we haven't changed the needle?
Dermatology services really hasn't changed a lot. So for a long time, CommunityCare has had 1 half-day clinic a week inside of CommunityCare. Seton had another half-day clinic, and that's where we have those services at Southeast Health and Wellness. the services that existed previously were at the North Central Health Center.
At the Breaker location?
Unfortunately, yes, at Breaker Lane. Unfortunately, those two clinics are not really able to keep up with the demand for dermatology services, and that's why we're working with our various partners to expand access to that clinic, and then any of the downstream services that are needed as a result of that clinic.
Okay, because you had alluded to other partners, and who are the other partners?
So
Other than Seton or CommunityCare?
right now, this is between CCC and CommunityCare for the clinic services. Surgical services will be with both the physician group that does dermatology at Seton and then the Seton facility. We're still in discussions with Seton about which facility we'll contract for these surgeries, and we're in the process of looking at how many of the Mohs surgeries we've done over time each year, so that we can contract for expansion of those services. So that's a separate exercise that's going on. We're also looking at other potential opportunities to partner with other clinic systems besides CommunityCare.
Like Austin?
Right now, the other clinic systems have to refer their patients into CommunityCare for services, and to the extent possible, we like to make these services available in the primary care home setting.
Okay. And then one last thing, so
ma'am.
you're gonna be coming down the pike, you're gonna come back to us for possible expansion so we can work on these numbers, but based on what this will do, hopefully it'll help move us.
Yes, yeah, and yes, ma'am, that's exactly why we're really hoping to expand to 2 additional clinics per week, which will actually it'll completely double the capacity of dermatology services for our patients.
At Southeast Health and Wellness,
At Southeast or North Central, or a
either
combination
one,
of those.
because they both have the facilities, they
Yes,
have the equipment.
And we really leave that up to CommunityCare based on the
Make that
availability
decision.
of staff and space in the clinics as well.
Okay, and with respect to, the last question, with respect to the community health workers, they already have 3 existing, so it's still, this is just the same 3 people who are gonna be,
These are the same individuals. They had grant funding to start that pilot, and now we're supporting the continuation of their pilot by reimbursing for services that are directly attributable to our patients. So the map is
that's MAP
slightly,
patients.
even though the services of those community health workers may be available to other patients that CommunityCare serves as well.
Is there an opportunity, will there be an opportunity to expand, to engage more community health workers?
I think so, and we have pilots underway with El Buen and Peoples as well, related to community health workers, and we're really taking a pilot approach to, we want to provide the room for these clinic systems to be innovative, how they put community health workers to work. We don't want to place a lot of strings on how they employ the community health worker and their practice model, and then we will end up doing retrospective reviews where we see how community health worker services were applied to our patients. And then I think there's absolutely room for additional uses of community health workers, both at the CCC itself and within our provider.
Thank you, that's it. Thank you very much.
Thank you, Manager Valdez. Any other questions? Model?
Well, mine is not really a question, more of a comment. I just want to commend you, John, and your team, Dr. Hernandez and Cyril, for all the efforts. People don't understand what happens behind closed doors, and I feel you are moving the needle, just going from A to B, just you expanding the services. I think it's been months in the working. It didn't happen overnight, and we deeply appreciate it, and I think the community has to be aware of. We realize we have a long wait time for patients, but it's not easy. The challenges are great, and I really want to commend you on moving forward and being you and passionate and really dedicated and assertive in what you are trying to achieve. Really, again, thank you and your incredible team.
We've got a great team working on this, and specialty care is a priority. It's been a priority as long as we've been here. And to your point, this is probably the hardest thing that we do, is improvements to specialty care, and it takes a lot of collaboration from community partners. It takes a lot of work on the part of our team. So thank you for acknowledging that.
Shannon?
Yeah, echo what Moran has said also. Could you tell me a little bit about the community health workers you currently have and how they are deployed and your contractual arrangement with them and the opportunity for expansion of that model to other communities and other community organizations that are doing community health workers?
Sure. So I'll start with, we really like to provide the opportunity as much as possible for our contracted provider groups to bring these ideas to us so that we're not forcing, here's how we think it should look. So it's really very different depending on whether that community health worker is employed by the CCC or within El Buen looks very different than CommunityCare or People's. I'll say across the board, they're used a lot for engagement in the community setting, so not just in the clinic four walls, connecting patients to social services a lot, to helping to break down some of the cultural and linguistic barriers of accessing care. They're also connecting patients to various social services and social service agencies and other city and county services that are available. They're used for chronic condition education for patients that are newly diagnosed with diabetes, for example. They'll, getting education from someone that is from your community and speaks the language that you do is a lot more effective than, from other members of the care team that may not have those characteristics. So there's a variety of methods. We employ a community health care worker in the CCC that spends the majority of his time in the Del Seaton Medical Center. He's connecting patients to eligibility. He's helping them to stay enrolled in MAP so that as they're getting discharged from the hospital, they're able to get connected. They're able to continue receiving communications. And really, it's the flexibility of this type of position that's the real opportunity for us. I think that's part of really the opportunity for expansion as well. There are a lot of different ways to deploy community health workers in our healthcare strategy. We're testing out a lot of those, and I think it's based on that retrospective review where we are able to determine in partnership with our provider organizations that those services are bringing value, we'll be able to scale up those solutions.
And I get that. That makes a lot of sense. I just want to make sure that those are reflective of communities that they're serving and that they are engaging in a variety of provider partners there, because there are large swaths of this community that are not reflected in terms of community health workers that need to be aged, those who are aged, those who have other cultural differences. And so I would encourage that as you look at your provider base, that you look at considering those as well.
That's great feedback. Thank you.
Thank you, Shannon. Additional questions? Okay, I have a motion by Manager Musaitis. I have a second by Manager Valadez. All in favor?
Aye.
Any opposed? Any abstentions? Motion carries. Thank you very much, John, and thank you for
Thank you.
all you've done. Appreciate it. I would like to lay out agenda item number 8, discuss and take appropriate action to establish vendor pools for the following services: architectural and engineering services, civil engineering services, and land surveying services. I will turn it over to Mr. Giesler.
Thank you. Members, the memo in the backup package is on page 52. And I'll briefly summarize it. Vendor pooling is a means to pre-select qualified firms to do work. That's the pool. Then after entering into contracts with those entities, you can then issue task orders for specific items of work. And we've taken a similar approach to communications in terms of how we pool vendors. And this is a means to efficiently and expeditiously move contracting forward. And in cases where we're using these firms for facility expansion, to me that translates into bringing services to patients, be it clinical or non-clinical services, in a more responsive and expeditious way. There is one correction I need to make in the packet memo. Under architectural and engineering services, this is in the top third of the page on page 53, second page of the memo. There's a firm, Corrigan. Corrigan was not selected.
Okay.
So that leaves the following firms, which is correct on your motion sheet: O'Donnell, Page, and then BSA Life Structures. Fiscal impact for fiscal year 2018, this current fiscal year, there's no fiscal impact. These items are budgeted for. And then obviously, as we move through the FY 2019 budget process, we will come back to you with the projected amounts or the we would request to fund these services.
Okay.
Are you looking to entertain a motion?
Well, thank you, Manager Valadez. I appreciate that. I am entertaining a motion. I'm trying to get it in my head whether I want to do all three of them or whether I want to do one at a time.
I can do all three.
All right, we'll do all three.
Forward, go for it.
All right, go ahead.
Okay.
A lot of reading now.
I can read.
All right.
I move that the committee recommend that the board approve the establishment of a vendor pool for architectural and engineering services in an amount not to exceed $150,000 to be allocated as appropriate among the selected firms, and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable than those presented with, and then the first one is BSA Life Structures, Inc., O'Connell Robertson, and Page Sutherland. Then I also move that the committee recommend that the board approve the establishment of a vendor pool for civil engineering services in an amount not to exceed $25,000 to be allocated as appropriate among the selected firms, and to authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable to, or than, those presented with Doucette and Chan, Jose Guerra, MWM Design, and UDF. I further move that the committee recommend that the board approve the establishment of a vendor pool for land surveying services in an amount not to exceed $100,000 to be allocated as appropriate among the selected vendors, and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable than those presented with McKim & Creed, MWM Design, Sherwood, and Stantec.
Thank you. Do I have a second? Manager Greenberg seconds it. So, do we have any discussion or any questions? Shannon?
What is the district's policy on MBE vendors? And how does it relate to those we have here?
On Hub.
Thank you.
I'm sorry?
So I'll answer that generally, and then council, if there's some additional information you feel the board needs, please add to that. But it's a good faith effort, standard, and I know Jeff had presented on this a while back, but looking at in future work, how do we improve upon that is something that we need to turn our attentions to. And then with respect to this, what we've listed here is the estimated hub participation, which was requested from each of the responding firms to the RFI. I'm sorry, RFQ, request for qualifications. My apologies.
Does that answer your question, Shannon?
Kind of, sort of, yes.
The standard is a good faith effort, Steve.
Okay, that's what I do.
May I add one thing to that?
Sure.
When the city and the county and the school district funded a disparity study, once that study was conducted and the results were found, at that time they had the ability to develop a policy, if I'm not mistaken, develop policies that addressed hubs and things like that, and how we're going to close the funding of entities, contractors, to be more reflective of the demographic. And Central Health did not participate in that disparity study. And so what we have in place as a result is, because they also found that they were actually better in the numbers.
Central Health is.
Central Health.
We
Central
are.
Health was better in the number of contractors the percentage of contractors that they contracted with than the city or the county or the school
We have a
district.
better record.
And that was without having participated in the disparity study. So I think that's a good reflection on Central Health.
And it was costly, as I recall.
It was going to be over 200,000 if I'm not mistaken, but either way, that's what that is.
Okay.
And then Then I had a question here. It said to be determined on McKim and Creed under the surveying services. What does that mean, to be determined, whether they're estimated hub participation? What does that mean?
So I'm not advised at this point. I'd ask staff if you have a,
Yes, I can answer that.
Stephanie's waving her hand in the back.
So that is the information that we had at the time that we shared this back with you as to what they anticipate their hub participation to be. We may or may not have had that information, and it may not be known. And what I'm referring to is subcontractors.
Right.
And so some
I
of that
understand.
will come out as contracts or task. It may depend on what type of task order is offered and what the subcontractors may be.
The end result may end
Yes.
up being a particular percentage.
That's correct.
Okay. Thank you. I just wanted clarification.
Great.
thank you.
Motion,
Any other questions? Okay, we have motions on the floor by Manager Valadez and a second by Manager Greenberg. All in favor?
Aye.
aye.
Any opposed? Any abstaining? Motion carries. Okay,
Thank you, members.
thank you very much. Item number 3, approve the minutes of the following meeting of Central Health Board of Managers Budget and Finance Committee, April 18th, 2018. Do I have a motion?
I move that the committee approve the minutes of the following meeting of the Central Health Board of Managers Budget and Finance Committee for April 18th, 2018.
Thank you, Manager Valadez. I have a second. Manager Aiken, I have a second. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Item number 4, receiving a report of the April 2018 financial statements for Central Health, and I'll turn it over to Lisa Owens.
Great, thank you. Lisa Owens, Vice President of Financial Operations. I want to walk through the April 30th financial statements with you. We are 7 months into our fiscal year and have collected year-to-date $180.5 million in our tax revenue. We also showed you a summary of the percentage of collection based on the tax levy, as well as what we budgeted, which is slightly less than the tax levy. And also a couple other highlights is additional risk-based capital that was transferred last week to Sendero, which was accounted for in the April financial statements. And we did receive our tobacco settlement funds, which I'll go over. We filed that settlement on behalf of multiple entities. Central Health's portion of that was $3.4 million.
How much?
$3.4 million. So our assets, our current assets were $156 million with $142 million in the short-term investments. You will see other on Sendero paid in capital. That number did increase from 51 million to 61 million this month, much with the recording of that additional $10 million in risk-based capital. And we had total capital assets of 117 million for total assets of $361.6 million. Our liabilities, our current liabilities are $23.6 million, and of that, if you look under other payables, you'll see the $10 million was accrued for the payment that we did make last week to Sendero for risk-based capital. It was recorded as of April 30th as a liability, but that has already been relieved and paid for. Debt service, our long-term debt service in our non-current liabilities is $8.3 million for total liabilities of $31.9 million. And that leaves our net assets at $329 million for total liabilities and net assets at $361.6 million. Our sources and uses through April 30th. Quickly, I'll go through the sources. We did have property tax revenue of $714,000. We also had lease revenue from Seton, from the parking garage and the CEC. As well, we recorded the UT ground lease, and you'll see a note that we did make a year-to-date adjustment there to account for that. Other revenue was $202,000, and our tobacco settlement, as I mentioned earlier, was $3.4 million, which is significantly higher than our budget of $1.8 million. Total sources of funds for the month, $5.2 million. Our healthcare delivery, which I'll go through on the next slide, $1.1 million. Our administration at $544,000. mostly made up of salaries and benefits. And our total uses of funds, $2 million, excess sources, overuses of $3.1 million. And getting just a little more detail on the healthcare delivery expenses, which were just $1.1 million this month. We did not have any intergovernmental transfers. We had primary care costs for our primary care contracts that are held by Central Health, as well as medical administration, which includes our member payment to the ICC. And then we had our healthcare delivery operating costs, which consists of personnel and other goods and services to operate healthcare services such as eligibility and enrollment. And again, there is a year-to-date adjustment there for the UT ground lease. We did have to make an adjustment from your Friday packet to correct a number on the monthly of $180,000. Our subtotal of healthcare operating costs for the month is $487,000. And then finally, our UMCB campus redevelopment and operations were at $214,000 for the month. And our other costs were total of $389,000 for a total of $1.1 million in healthcare delivery costs for this month, a total of $113 million for the year to date. And the last slide shows you our year-to-date IGT. We did not make any transfers as of the end of April, so that has not changed since the previous month.
Okay, do we have any questions?
I just have a question, on more capital than anything. The damage that was done to the facility the other night, how's that?
Campus Health and Wellness.
So, the insurance companies have been contacted. I have not been advised of what the recovery amounts might be. I think that's, anytime you adjust a commercial claim like this, but there is insurance, buildings, and then, this is the reason why, we talk, when we show our financial forecast, we have those reserves, specifically emergency reserves. I think that very incident underscores the need to have those reserves to the extent that the insurance policy does not cover all the damages.
The insurance policy has been initiated, the recovery claims process.
Is that our insurance policy or his?
That's between the insurance companies.
Do you have an estimate on how much the damage is?
Not on topic.
We're not on topic on that one, but I can,
Oh, okay.
when we send an update to the board, we'll make sure we address that.
Perfect, thank you. Okay. No, hearing no other questions, we will lay out agenda item number 5, receive and report of the April 2018 financial statements for the CommunityCare Collaborative. Lisa and John.
Great. Well, I would like to go through the financial numbers and then turn it over to John to talk through just an update on our DSRIP project costs and our specialty care. So if you don't mind, I will quickly go through the slides and then John will, I can answer any questions, and then John can kind of hit some highlights on where we are with our specialty.
Okay.
So again, this is also as of April 30th. Our cash and cash equivalents is at $63 million. Our total assets, predominantly made up of cash, is $63.6 million. We do have accounts payable and liabilities of $23.5 million, which is mostly accruals for provider costs, as well as intercompany expenditures. Our total liabilities is $26.8 million with net assets of $36.8 million. And year over year is looking very consistent with where we were last year at this time. Our sources of funds, there have not been significant changes to our sources of funds, other than our other sources increased from additional interest income. We have not received any additional DSRIP or member payments, but we did have a slight increase in our other sources of funds, a total of $79.7 million, and our healthcare delivery year-to-date at $47.9 million for sources overuses of $31.8 million. Primarily, our healthcare delivery is our major use of funds, and again, as I said, I'll turn it back over to John in a minute to talk a little bit about our DSRIP project costs. And then on slide 5, which is the next, we have an outline of the healthcare delivery costs. Our largest component being our primary care, which we have an additional slide on, as well as significant expenses in our behavioral health and specialty care, longstanding programs, as well as $2.4 million in pharmacy. We also have $1.3 million in our medical management, as well as other healthcare delivery options of $4.74 million, which our total healthcare delivery operations is $47.3 million. We are at about 46% of the budget, which is under budget, but you'll see for some of our primary care contracts on the next slide, we are tracking right at about 55%, which is good for the year. More standard operations in our primary care settings. We do have approximately 56% of the budget incurred as of the end of April for CommunityCare, and we continue to report out tracking well for our other 4 major clinic partners. In addition, you'll see a small cost incurred in April for prevention and wellness with the launching of our diabetes prevention program, which will start to pick up pace as the year closes out. And then our total primary care expenditures year-to-date, 55% of budget at $28.6 million. I'm not going to go through the details of the specialty care. I'm going to let John talk through that, but we are at $4 million. We have added, at the board's request, the prior year-to-date actual, and I would just like to highlight that prior year-to-date versus current year-to-date, we have spent over 30%, which is significantly increased over last year at this time. And then finally, you'll remember from the budget that we have quite a few operating departments that are helping with the transformation and the quality and the data components. So we have outlined their approved budget and where they are year to date. This is primarily salaries and other goods and services in these departments. Some of them have been longstanding departments, eligibility and enrollment, new this year with the transfer of some of our contracts from Central Health to the CCC. And again, they are at 37% of budget at $4.7 million. So do you want to?
Can we go back to slide 4?
Yeah.
So what I'd like to do is hit a few high points on a few slides, but first give a little bit of context. I'll likely be joining Lisa at least quarterly to help put some context behind these numbers. I give a pretty general disclaimer that I would encourage everyone not to really use the healthcare delivery financials as an indicator for progress or work being done in these areas for a variety of reasons. One being that like any kind of healthcare payer, we have a fairly significant delay from when services are provided to when costs are incurred and when we receive bills. Generally speaking, our providers have up to 90 days to bill us, and then our payment and appeals process related to claims payment can go out quite a while, 6 months or even longer. Our annual financials really force us to take a continuous process and put a hard start and a hard stop on it. That's really not the nature of the business. These are ongoing services, and trying to fit things into this structure can be challenging at times. So at least quarterly, I'd like to join Lisa, or really as other material changes take place that we need to update you on, just to provide some context behind some of these numbers. The first example is on the DSRIP project costs. During our budget process, we budgeted about $17.9 million related to DSRIP. That's a new program, a second round of the DSRIP program for us. One of the significant changes to that program is it moved from aligning with our fiscal year to now being based on the calendar year. So initially, we anticipated a lot of expenses to occur up to 17.9 million in FY18. Because that now shifted to a calendar year, the vast majority of those expenses won't actually be incurred until 19. So now, and even at the end of the fiscal year, our end-of-year estimate is going to be well below the 17.9 million, but we'll need every bit of that rolling forward to take care of district expenses in FY19. So I wanted to provide that context. We're also in the middle of executing contracts with our service providers related to those district programs. So we will start to incur some startup costs over the next few months, but again, we'll be far below that 17.9 at the end. Primary care, yeah, I just want to touch on volunteer clinic, obviously is ahead of budget quite a bit. Historically, volunteers wanted to cap the amount of contribution that they receive from any single source. So even when they hit that contract not to exceed amount, we have a conversation with them about what they need to maintain services. And, you know, we will work with volunteer. I have the ability with administrative authority to increase the amount that we pay volunteer if needed based on conversations with them. But we certainly want to ensure continuity of service at that clinic. And specialty. And this is a very, very busy slide. And I want to hit a few highlights here. I'll try to be very brief. There was a memo that I wanted to provide in advance. I believe it showed up in the Board of Managers meeting packet last month that highlighted some of the specialty care work that we have going on. I won't go through all of that detail, but I'd encourage you, if you have questions, to look to that memo, and then I'm always available for conversations if you'd like to know more about the work that's going on in this area. I'll just go down the list very quickly and hit a few items. Consultation and referral platform is the platform that you all approved for us to implement this year. We are currently having contract negotiations with that vendor, including some face-to-face negotiations. They're coming down from Chicago so we can finish that up. We hope to have a executed contract in June and start implementation in the fourth quarter, so that by the beginning of FY19, we have a large part of that system from a referral management standpoint in place. And then we will, once we have the referral management system stood up, we will move to start e-consultation programs with different providers. Cardiology, we've spent about $40,000 of our $150,000 budget. Just to remind you, this is the TAVR, the transaortic valve replacement budget. I won't try to describe a second, clinical program tonight like I did earlier with dermatology, but this is a very narrow group of eligible patients that need this service, and we were able to provide our first TAVR surgery in January of this year. It was the first time one of our patients have had access to that service, and we're very happy to have been able to provide it. Because that's such a narrow group of patients that are eligible for that service, it may be that we use the $150,000. It may be that that's the only patient that's identified that qualifies for that service this year. So that number may or may not change as we move forward. With community care specialty, again, these are the services that are provided at Southeast Health and Wellness and at North Central. They are moving along as expected. We do have the additional dermatology budget right beneath it that is available as we expand services from the item that you all approved today. ENT is our pilot with Austin Regional Clinic. That's been very successful for us. In January, we were able to expand to 2 additional half days with ARC, and we've fortunately been able to reduce that wait list from around 500 patients last year to less than 200 this year. We're making some pretty substantial progress there. One limitation that applies to ENT as well as to the gynecology IPU and to orthopedics is today we're only able to serve the MAP patients in those clinics. And the creation of the program, the enrollment program that this board approved earlier in the year, will allow us moving into next fiscal year to start serving sliding fee scale patients through these programs as well. So we're really excited about that. But our ability to impact wait lists has been limited just to MAP patients due to not having an actual enrollment, being able to offer a pharmacy benefit and adjudicate claims related to those services. Palliative care, a little further down the page, is a new program. That contract will be executed before the end of this month, and we'll start to see those services. Those are home-based palliative care services brought by nurse practitioners with a group that we've never contracted with before, so we're very excited to see that come online. Physical medicine and rehabilitation is a new program. We're still working with Seton to get that put into place, hoping for a go-live in the fourth quarter. Remote patient monitoring, this is a collaboration with CommunityCare and Good Health, the call center and virtual care organization within Seton. Last week, I would have told you that we were putting that off until FY19 in recognition of the very heavy lift of DSRIP for our primary care providers and trying to really focus on DSRIP. However, in conversations with CommunityCare, they'd like to keep that initiative on, and it's going to, we're hoping to layer this remote patient monitoring service on the real highest need patients inside of CommunityCare that are served at the complex primary care clinic. So we're still working towards that, likely a service that'll come online very late in the year. So I wanted to make sure that you all are aware of that. Rheumatology, you all approved, I want to say it's last month, those services, we're finishing that contract with CommunityCare, and those new rheumatology services are going to be starting in CommunityCare this month as well. And then urology is the last one, before I'll make one more general comment. Working with Seton, we've been able to expand the urology clinic as of this month, the first part of May, so we have additional clinic services in urology. That spend and the number of patients that can receive both clinic and surgical services related to urology will pick up for the last part of this year. Last comment that I'll make is Jeff and Lisa and I are looking at the format for the financials, and as we bring the budget forward this year, we'll be bringing forward some recommendations on how to present some of this information differently. I think it's hard to follow, it's hard to understand. At times, we have a lot of new initiatives that appear on the month-to-month financials as if nothing is happening. So rather than planning, or rather than having individual budget line items for services that are going to be in planning part of the year, we'll likely have a budget category for new initiatives, and then once those initiatives are turned on and operationalized, we'll turn them into individual line items that are reported. That way, you can better track the activities and as they're coming online. So, happy to answer any questions. Thank you for bearing with me.
Excellent explanations, and thank you very much, John, for that. That'll make things and make our visualization of things much easier as we look at the plan. Okay, I have two questions. I'll take Madam first, and then Cynthia second.
Well, thank you both. Thank you, John. I really appreciate it. I just have a comment. Slide 4, if you can go back. I'm just out of curiosity, how does the member payment work? Because I see Central Health approved, but it hasn't really contributed zero, so I'm just...
All subject to the master service agreement.
Okay, thank you, that's it.
Thank you. Cynthia?
With respect to page 7, with specialty care or with primary care, wherever we have the various departments, identified, is it possible for you to give us, and I've asked for this before, and I didn't know if there was a reason that they didn't do it. I wanted to know the number of patients, so I could kind of look to see what the cost breakdown is. How if it's one person, that's having that surgery, then I'd like to know that was the cost of for one person. But if we have like 350 people, I want to know if it's 350 people for this particular cost.
Yep. Absolutely.
And it would help not only us, but it would educate the public as to what the cost of doing business is for providing the medical services and the hospital services that we're doing. And so I'd like to know if that's possible.
We have started compiling that information, and that's going to be incorporated into our budget presentations that are starting even as early as next month, so that we can really answer that question of what are we getting for our money?
Well, that's right.
Each of these contracts, the number of people that we're serving, and the types of services that we expect them to get in each of these contracts.
That's right.
So we'll have that breakout for you of really what you're paying for in each of these.
So as we get to the point where we're compiling our year end, you know, and these are the added value things, and this was that, and we have a better idea as to what the costs were and the cost of services that may not necessarily be the medical services, but the additional things, we would have a better idea as to what that cost is.
Yes, ma'am.
Seton Healthcare Family Specialty, what is that?
That's the collection of specialty clinics that Seton offers. We have an expanded services agreement. That's a long-standing agreement. I believe it started in 2013 when the master agreement was executed and the CCC was established. So that line has decreased almost every year as we've taken on initiatives to move services out of that hospital setting and into the community. But there are still specialty clinics that Seton offers today, even though, you know, a large portion of that we've now moved to either to CommunityCare or to other clinic systems in the community like ARC for ENT services.
Can you give me an idea of what we're talking about?
This could be cardiology visits
Okay.
that happen inside of Seton.
This is not through ER, and this is not hospital,
These are
just to their family.
clinic-based services, and then ancillary tests or procedures that happen as a result of those clinic visits.
Is this located in the main hospital, or is this located somewhere else?
The contract is really system-wide for Seton, so it's services that they provide to our patient population above baseline levels, and it's across their hospital system or across their clinic systems, and the mix of those services has changed over time as we've taken on additional projects.
So as we look at the development of, like, do our mapping eventually, and tie that to what we're doing here, and projected planning and actual votes on our budget, is there going to be a time when we're going to be able to see those places?
See where the services are offered?
Yes.
I believe so, yes, ma'am.
Okay, thank you very much.
Thank you. Any additional questions? Thank you, John. I appreciate that. And Lisa, thank you for that information and the reports. And thank you, members.
Thank you.
Appreciate it. All right, item number 12, confirm the next regular Budget and Finance Committee meeting dates, times, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is on Wednesday, June 13th, 2018 at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702.
With adjournment.
I have a motion for adjournment by Ms. Greenberg. I have a second by Manager Valadez. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Thank you very much, members.
Are you going to give everybody a reminder about Monday?